Hello, my name is Tanja and I present to you ankle-foot-orthosis management during rehabilitation of persons with incomplete spinal cord injury, a patient perspective. Persons who have sustained a spinal cord injury require specialist care and rehabilitation. In particular, the use of lower limb orthoses for those with incomplete spinal cord injury aim to facilitate standing, mobility and functional independence. There are 11 specialist spinal cord injury centres across the UK, with the Queen Elizabeth National Spinal Injury Unit in Glasgow responsible for the management of all patients with spinal cord injuries across Scotland. They have a dedicated spinal unit service with inpatient programmes, which includes orthotic management. The spinal unit itself publishes annual audits of epidemiology of spinal cord injuries, and within the last 10 years there were a total of 104 admissions of those with incomplete spinal cord injuries. A literature search investigated the evidence regarding the efficacy of AFOs and demonstrated that different designs of AFOs have an immediate positive effect on gait parameters, kinetics and kinematics. However, none of the studies investigated the impact of AFO use long-term or investigated patient satisfaction with the AFO either immediately or long-term. Rehabilitation should be patient-centered, so it is important that clinicians and researchers consider patient views regarding impact of orthotic management and identify factors which may influence abandonment. Therefore, the purpose of this study was to investigate the experience of AFO management, factors influencing AFO use and device abandonment in those who have sustained an incomplete spinal cord injury, who were treated at the spinal unit in Glasgow and discharged wearing AFOs. Ethical approval was granted and permission given by the Caldecott Guardian to access and analyse anonymized patient data. A paper and internet-based questionnaire was developed which comprised of 35 questions subdivided into 4 sections. Section 1 provided information on patient demographics. Section 2 informed about specific details of the AFOs and perceived benefits and/or issues associated with use of AFO for those who reported continued AFO use. Section 3 offered a series of open-ended questions to those who ceased using their AFOs to understand their reason for abandonment. Section 4 explored the provision of AFOs, review procedure and subsequent AFO replacement following discharge from the spinal unit in Glasgow. When the inclusion criteria was applied, 66 patients were identified by the spinal unit who were subsequently invited to participate in the study. For the qualitative analysis, ordinal logistic regression was used to identify whether differences in perception of AFO use were associated with variables within patient demographics and skin problems experienced. Binary linear regression was used to investigate if abandonment was related to variables within patient demographics and skin problems experienced, and to investigate if skin problems were associated with uni or bilateral use and the ability to don footwear over the device. The participants' demographics, characteristics at time of injury and comorbidities that may impede walking were analysed descriptively. There were a total of 22 responses, which is reflective of the expected response rate for postal questionnaires as referenced here. Now, the questionnaire provided an extensive amount of data, so due to time limitation, I will only present key information. 12 of the 22 that responded are still wearing their AFOs, with majority of them perceiving AFO use as positive on walking ability and speed, standing and walking balance, which is fantastic. 3 of these 12 experienced skin problems with AFO use. 1 altered palate AFOs him herself satisfactorily. The other 2 are continuing to wear their AFOs despite ongoing skin problems. They reported blistering, skin breakdown and bleeding, with 1 also experiencing ulceration with ongoing attendance at podiatry for wound management. This is concerning as it not only impacts negatively on quality of life, it puts the patient at an increased risk of infection. Let's move on to the 10 that have discontinued the use of AFOs. This graph demonstrates abandonment timeline, with 6 out of 10 abandoning AFOs within the first 12 months following discharge. The most common reasons for abandonment were skin problems experienced and an inability to fit shoes over the AFOs. The abandonment of the device has ultimately led to waste of healthcare resources and negatively impacted on the patient's ability to realize their optimal rehabilitation goals. Now we can only speculate if the AFOs fitted pre-discharge were appropriately designed, fitted and aligned, as the study only reports on patients' own perceptions of AFOs. We have to keep in mind that these patients transition from 24/7 care within the spinal unit back into their own environment, where they are likely to encounter problems. This life-changing injury can impact their mental health significantly, and it may as well be that these patients did not consider AFO treatment as an essential requirement when faced with the many challenges following discharge. Poor compliance with AFOs may lead to the developmental of contractures which will impact the fit. Deterioration or improvements to functional status may mean that the design or fit of the existing AFOs may no longer be appropriate. Furthermore, secondary complications such as weight changes may negatively impact fit and function of the existing AFOs, leading to abandonment. On discharge from the spinal unit, ongoing orthotic management is provided by the local health board and orthotic service. 4 did not know who to contact should they experience problems with their orthosis following discharge. 10 also reported that following discharge they had not received a review appointment from their local orthotic service. In the absence of this information, patients experiencing AFO issues may subsequently abandon them and make them less likely to seek out or comply with future orthotic intervention. There is a clear benefit associated with AFO use demonstrated within the study. However, it is clear that there are issues if many patients abandon the device within 12 months. Currently, patients receive a very informative booklet. While Section 3 includes excellent information on the use of upper limb and hand splints, there is no information on orthosis for the lower limbs. Section 4 and 6, which cover discharge planning and appointments, should provide details on the local orthotic service provider and what will happen following discharge. A procedure must be implemented to ensure a transition plan is in place for these patients before being discharged back to their local orthotic service. A discharge letter to the GP and local orthotic service with extensive information on patient's functional presentation and current orthotic management is essential. This should also include a simple basic validated outcome measure, such as the time up and go test, so that the patient's status can be monitored during their transitioning period following discharge. There is a clear need for the use of outcome measures to monitor their psychosocial and mental health, which can be significantly impacted by this life-changing injury, which can influence device abandonment. Therefore, more regular follow-ups with their local orthotic service or the spinal unit would be beneficial, with mobility and quality of life measures taken at each appointment. Regular face-to-face clinical appointments may not always be feasible, as some patients may have to travel extensive distances to these specialist clinics. Virtual appointments, which have become increasingly integrated into clinical services during the COVID pandemic, would be beneficial. Lastly, there are standardized screening, fitting, review tool and orthotic referral forms already established for stroke patients in Scotland, which could be adapted and used for patients with incomplete spinal cord injuries following AFO provision. These would allow any healthcare professional or GP to review the AFOs and refer to orthotics when required. I would like to thank the patients who participated in this study and welcome correspondence from individuals who have questions or would like to find out more about the study. References can be found at the end of the presentation. Thank you very much for listening.